Hello and welcome back to Global Mental Health Advocacy Forum 2024. Uh, we have this session organized by Global Mental Health Action Network, and we are here to celebrate the breadth of mental health advocacy work that's happening all around the world and to create spaces to learn, connect, and strengthen our collective impact. This session has been organized by the Action Network Suicide Prevention Working Group with the specific intention of highlighting the local and national strategies for suicide prevention. And today we are going to be covering the latest developments in global, national, as well as regional suicide prevention efforts with a special focus on the Caribbean, Asia regions. And we will also be building on the advocacy aims of the working group. And finally, this is also a chance for all of the working group members and global mental health advocates to connect and build relationships that could improve the joint working capacities that we have to drive collective action. And to this end, may I request all of you to share your name, affiliated organizations, as well as your country in the chat to get the ball rolling. I'm going to begin. I'm Dhriti Agarwal, the chair for this evening, and I'm so glad to see so many people joining in from all different corners of the world. Apart from being a member of the Suicide Prevention Working Group, I'm also the co founder of a mental health helpline based in India. My lived experience in suicide and sexual violence, as well as my training in global mental health and community suicide prevention, do guide my work. I am currently engaged with a range of organizations based primarily in India on issues of gender, health, and mental health within communities. And my experience has reiterated what research has found, which is specifically that for every completed suicide, we have many more who have attempted suicide. The rate in India is 20 times the rate for completed suicides. We also know that one of the leading causes of death is suicide, especially within the adolescent communities. And this burden is disproportionately carried by low and middle income countries. But there is light at the end of the tunnel because we also know that while suicide is complicated, it is preventable, especially with timely, evidence based, as well as low cost interventions. When suicide is made a national health priority, countries have been able to pull off national subpopulation and community specific steps towards prevention. And to talk more on this, we are joined by two very strong voices in the field of suicide prevention. We have Dr. Margaret Chatur, who is an assistant professor at the University of Trinidad and Tobago, and she is also a co-chair in the Scientific Community for International Association of Suicide Prevention. Dr. Chatur, could I invite you to share a little bit more about your work?
Good morning, everyone. So I'm Dr. Margaret Nakachatu. I'm also a past president of the Trinidad and Tobago Association for Psychologists. For many years now, we have been looking at suicide prevention, especially in the Caribbean, as some of our countries, Trinidad, Guyana, Suriname, Cuba, Haiti, have some of the highest rates of suicide, especially among the male population. So as an advocate, I've been writing a lot of public awareness articles on this, running gatekeeper training programs, especially for university students who are volunteers in the suicide prevention advocacy group, and having essentially public awareness on the issue. As you know, mental health continues to be a stigma in islands like Trinidad and Tobago, in Guyana, and in other islands, St. Lucia, etc. So at the moment, we have a regional coalition, which I'll speak to a bit later on, which is going to, I suppose, speed up the momentum of what has been happening over the last 2 years. And I think all of this has come to the fore during COVID, when we realized that the suicide rates had increased phenomenally, especially among the male population 15 to 29 and the over 60 age group male population also. So efforts started there. I started a crisis intervention hotline in 2020, March 2020, and it continues to date with more than 2,200 callers. So yes, the time has come where we're not just walking the walk, but talking the talk and doing all of the things necessary to carry this forward. Thank you.
Thank you, Dr. Chatur. And I'm also going to take this opportunity to introduce Dr. Ginger Ramirez, a public health physician with the National Center for Mental Health in the Philippines. Her public health experience spans various health systems, right from rural primary care communities to the National Department of Health and international consultancies. Dr. Ramirez, may I invite you to introduce yourself further?
Thank you very much. I am Dr. Ginger Ramirez from the Philippines. I am a public health physician. Actually, I would consider myself as relatively young and new in terms of the field of suicide prevention. But my experience has really been in public health in general and working for local and government and national government, doing more policy and program development. No, and I previously worked in health facilities, and but when COVID hit and when we were in the middle of the pandemic, working with the different agencies, it really did feel like it was time to focus on mental health and to focus on suicide prevention, because while we were working with some friends and colleagues in the national government, asking them what their needs were, in the middle of the pandemic, this was August of 2020, we thought that they were going to say, oh, we need oxygen, we need hospital beds. But one of the things that really the mayors and the local government officials brought up was that people were dying by suicide. And that really took me by surprise. And it really highlighted the need, because it was there were very few resources to share with different stakeholders. So relatively new in the field of suicide prevention, but I've done research on suicides with adolescents as well, and working with them after they have had a previous attempt. Also working with different healthcare professionals, specifically psychiatrists. And I am currently with the National Center for Mental Health. One of the main assignments that I have is to work on the surveillance system for suicide attempts and self harm. So we're working on that policy as well as the national suicide prevention policy of the Philippines.
Thank you both. I think it's absolutely an honor to have you and your vast experiences in clinical practice, public health systems, as well as suicide prevention organizations here with us today. I want to make the most of the time I have with both of you, so let's jump right in. Before I start with the first question, I do want to request the audience to submit any questions you have in the chat, and one of us can answer them either during the session or in the chat directly. So let's start. If I'm thinking about India specifically, the prevalence of suicide in India is higher than the global average. And while the 2017 Mental Health Care Act did decriminalize suicide, it was only in 2022 that we had a national suicide prevention strategy that came up with a focus on making suicide a public health priority, limiting access to means, whether it's pesticide, firearms, as well as encouraging responsible reporting from media, and finally, fostering social emotional life skills in adolescents. But I think I would like to understand from both of you what are some of the most successful examples of national suicide prevention strategies that other countries have that could be followed. And I think I would like to start with Dr. Chatur. You were involved in the development of the regional coalition for decriminalizing suicide and suicidal behavior in the Caribbean. So, what are your thoughts?
So thank you. So some context to the regional coalition that has been developed before we go into the prevention strategies that we've been looking at. So suicide and attempted suicides were incorporated into our colonial laws based on Section 12 of the Supreme Court, and they were passed and in operation as was happening in England, so that it continues in these Caribbean territories to be a punishable offense. And at the moment, we have islands like St. Lucia, Grenada, the Bahamas, and Trinidad and Tobago who are pushing towards the decriminalization of suicide. As you know, the criminalization of the act can hinder persons from seeking support, and the existing laws continue to perpetuate the stigma and the discrimination against persons. So this year, from April 28th to May 3rd, a workshop was conducted by the United Global Health Group to rally support of professionals, advocates, persons with lived experiences, SCSOs, and mental health experts to facilitate a regional coalition on this issue and to structure, more importantly, a human rights response for suicide that was also context specific to this Caribbean region. And I want to mention that I'm really um, fortunate to be part of this group, especially as I think it is a youth led initiative by young persons themselves. And I think this is very important in moving this forward. So, some of our aims and objectives of the regional coalition is to advocate, as I said, for the decriminalization of suicide. Attempts have been made by our own Ministry of Health in Trinidad and Tobago. So, we want to support these efforts and move it forward with our political support from the government itself, from also multilateral institutions such as PAHO, the UNDP, and UNICEF, and our international organizations, very important, such as the IASP, the United Global Mental Health and Lifeline International. And again, this is to connect with persons who have been there, who are successfully assisted other countries and their own in the decriminalization of suicide. So at the moment, some of our actions are to again mobilize stakeholders to champion the integration of suicide prevention strategies into a national working mental health plan for each country and to develop policies around this. And therefore, I am glad of this opportunity because we know that nothing can go forward if we do not have the support and the coverage of media personnel, such as what we're having now, to have the momentum to move this forward. So, yes, so some of the national suicide prevention strategies, and I will speak specifically to Trinidad, that we have been doing thus far as I mentioned briefly, gatekeeper training young persons, professionals, lay persons, teachers, etc., to recognize the signs of suicide ideation, to connect individuals to appropriate resources. Another intervention is our crisis hotlines, the one that was established in March 2020 and continues today. We have in Trinidad Childline, we have Lifeline, and we also have a national suicide prevention hotline established by the Ministry of Health in November 2023. So these hotlines are especially important for individuals in distress and where they can seek immediate support under the conditions of anonymity. Because, as I said, it continues to be a stigma where persons do not want to seek help because in small islands they think everybody knows everyone. So that on the telephones, it's a condition of anonymity and, of course, confidentiality. And a third strategy that we're looking at is the awareness of reducing access to lethal means. In the Caribbean, two of our main access to means are the use of pesticides and through hanging. So we want to implement measures, especially for persons to be aware in their homes of limiting access to these lethal methods of self harm. We have a lot of young people, especially, cutting and speaking about suicidal ideation, and of course, limiting access to pesticides, medications, and firearms. And our fourth, hopefully great strategy would just not just be the public awareness campaigns, but as an educator myself, to push this into school-based programs to introduce these mental health awareness and education programs into schools to equip our students with coping skills, with resilience skills, because many times, often, they do not indicate to parents what's happening with them. They feel that adults cannot understand, that they do not understand. So I think peer initiatives in this make is very important. So those are among our four campaigns, our four strategies.
Thank you, Dr. Chatur. I think I do see a lot of similarities between the work that's happening in the Caribbean as well as India, whether it's the decriminalization, making it, reducing access to lethal means or engaging with the media as well as in school settings. Dr. Ginger, I do especially want to hear your thoughts as well, based on your experience on the Philippines national strategy, as well as your learnings from studying youth mental health lived experiences.
Yeah, thank you very much. Perhaps I want to start with start with data, like the importance of data, the importance of having information that will help us make decisions. So, being in the field of policy development, of course, that's very high level, and we are able to develop programs and policies for the entire country, and of course ideally those policies are based on data, and I think other countries who have other countries in the Asia Pacific do have surveillance systems already on suicide attempts and self-harm, but very many still do not have any data, and even data on deaths that are coming from death registries. The quality of these registries are not might not exactly be high level. So there's a varying level of quality across the different countries. In the Philippines, thankfully, our death registry quality is relatively okay. According to a WHO report, it was relatively high quality and useful. So that's great. But we do not have any data on attempts, at least not data that and can be easily extractable and analyzed. So, from our experience trying to set up the surveillance system, we realized that all physicians, for example, in an emergency room, and if there is a suspected case of suicide or if a patient comes in for suicide, everyone asks about the attempt, everyone asks about details in the history. But those details are in narrative form in the chart. So it's not usable by even clinicians within the same system. They cannot share it across the different agencies as well. And of course, there's no way to get a national level data. So I think one of it's great that in the even in the strategies promoted in the live life framework, the importance of having surveillance data that's going to be useful and speaks a language that is understood across the different institutions as well. So right now, the Philippines, we're working on the surveillance system. We are yet to finalize the policy that will be based on that. But we are already working with the different health facilities, and also particularly working with different clinicians. So these are not just mental health clinicians or psychologists, psychiatrists. We have to start having discussions with the surgeons, with pediatricians, because a lot of the injuries end up being referred to surgeons, and if they're not used to collecting information on suicides and collecting specific information, then it would be a waste to not get that. No, so that's one of the things that we're trying to work on now. And but one of the other I think lessons that we can learn from this is again like the use of language. So one of the things that we found has been very helpful in advocating for suicide prevention in the country is the use of proper terminology. So we hear that a lot, like what are the terms that you should use or should not use. So what are the terms that promote stigma or that kind of address that? What are the terminologies that are acceptable to the youth, no, the terminologies that they will understand as well without sugarcoating anything. So I think having that language is important. But going back to data, even language on how to code these attempts. So it's been very kind of tricky for us to kind of advocate for using the ICD-10 codes, just so it's something that we can collect across health facilities. So even language at the like technical level needs to be clarified and needs to be agreed upon between the different stakeholders. So like that's one thing that I wanted to share. The second is about the crisis hotline. So as Dr. Chatur mentioned, the crisis hotlines are very important. And in the Philippines, that's one of the areas that has been focused on a little bit more. But one good thing that I think is present now is that the public and private partnerships are there. The role of the private sector, at least in the Philippines, is very important, as almost half of our health facilities or our health system is private. So there definitely needs to be a complement between private and public sector to fill in the different gaps, because there it seems that it's impossible, of course, for government to address everyone's needs. So I think it's great that different groups have had their own crisis hotlines, and some of them have it in different forms. So as mentioned, in terms of like anonymity, even like sometimes like calling might be difficult, but texting might provide more anonymity and comfort to the individual who is trying to call for help. No, and the third thing that I want to share, and I think this is something that also I've been learning about, that's important in the region. I think in other areas as well, but one of the things that I've been thinking about more is the role of like culture and religion. This is something that I've learned in the recent conference of the IASP, the importance of religion. So the Philippines is almost 80% Roman Catholic. So there is a the church has a very important role. And I think in other countries like Indonesia, who's predominantly Muslim, or like even Malaysia. So the role of the church or the religious institutions, I think there's more interest in engaging them. And thankfully, we seem to have progress there. I don't have any like specifics right now, but I think just the awareness of involving the different institutions and the willingness of the institutions to kind of rethink their how they share their faith, their teachings, their practices. I think that's something that's great, and it's it's something that's positive for all of us.
Thank you, Dr. Ramirez. I think that all of the points that you've mentioned, whether it's about the importance of data collection, the contextualization that needs to happen around language, around religious beliefs, as well as the interdisciplinary approach that needs to be taken around suicide prevention, is all very relevant. Right. That's helpful. I think I also want to understand from both of you that when we are thinking about suicide prevention programs, whether it's limiting access to lethal means or encouraging media, data collection, issues around engaging with religious institutions, all of these, I think one of the crucial questions that keeps coming up is that how do you evaluate the effectiveness of these interventions, especially when we're talking about suicide prevention, where we're uh, putting in efforts towards something not happening. And while a whole day's worth of discussion could be had around this, I do want to understand from both of you what are some of the ways that these interventions can be sort of monitored and for from a effectiveness angle. So, Dr. Chatur, maybe we could start with you.
Yes, let's look at that. It was quite interesting to hear Dr. Ramirez's talking about what is happening in the Philippines, because there are so many similarities within the Caribbean context. And as I said, when we look at process implementation, we have to look at what is specific to our Caribbean area, our area, with so many suicides. And I think she mentioned two things that has to happen to make suicide prevention programs effective, and that is the reliable and robust data collection that needs to happen on suicides and suicide attempts. I think when I have spoken to many doctors in the emergency wards, they tell me that clients come in, patients come in, and accidents are not labeled as incidents or attempted suicide. So I think the questioning has to happen. Did you attempt suicide? Do you think are you thinking of taking your lives? And that is where training and development of our mental health workers come in, our doctors or the nurses who receive these patients coming into the emergency wards. So even though our rates are very high with suicide, I think they are higher because they are not properly recorded. The data collection is not as reliable and as robust as as can happen. And Dr. Ramirez also spoke about the religious taboos. And the Caribbean, as you know, is very Catholic oriented, lots of Islam, lots of Hinduism, all structured religions that do not look upon suicide very favorably. So we have to, the public awareness where this is not a morality issue, but it is a mental health, it's a public health issue. And to move it forward, move the conversation, move the narrative forward in that direction. So if we have to evaluate the effectiveness, I think one, looking at the process. What, when we implement all of these programs, what are we looking at? Are we tracking the number of persons with whom we identify? And if we are tracking them, are we delivering proper um, services to them after suicidal attempts, etc.? We have to understand also how these persons are engaging in the programs that we are implementing and evaluating the quality of services. So process is important as well as the outcome. So when we look at the outcome of these programs, we have to look at between 2022 to 2024, has there been a decrease in suicides? As we move forward, has there been a decrease in suicidal attempts? And if not, what are the alternative outcomes? What do we have to look at? Do we have to improve the identification of risk factors? Do we have to improve the public awareness of risk factors? And also, what are the protective factors that are there that we can look at, that we can strengthen in our homes? One of the main issues I look at outcomes is that COVID has shown us that we don't really know who are our vulnerable groups in the society and how do we reach them? How do we reach, whether it is via mobile units, whether it is sending persons to these remote areas where there is little access. And we take it for granted sometimes that persons always have the means to access mental health facilities. Some of them can come from very impoverished situations. Some of them do not even consider that their issues may be mental health related. So, again, in looking at process, we have to look at outcome, we have to look at enhance access to mental health care, increase social support for these participants, reducing access, as I said before, to lethal means, and the practical considerations of one, collecting data consistently, collecting data that is practical, collecting data that leads us into looking at suicide prevention differently, and that is cultural and context specific.
Very true, and I do have a follow up to that, considering that the focus both of you have brought to data collection and monitoring, especially when we're thinking about that in the context of the importance of confidentiality, the importance of anonymity, as well as the fact that it is criminalized in a lot of countries. So, how would you suggest going about data collection while respecting anonymity, while prioritizing confidentiality simply for protection of the clients?
Yeah, and this is where the training and development of our healthcare workers come in. I always believe that with any intervention, it has to be multi-pronged. Not just the doctor there, but the social worker possibly who is alerted to what is happening, comes to the emergency rooms and takes data on that particular individual, what's happening in the family, is there a ripple effect happening? So, and understanding that you're not going to be prosecuted. Nobody is going to know. This is confidential. We are here to help you. And many times I think that when patients come in, they are very fearful. Who is going to find out? My mother find out? Who is going to know? We have to alert our healthcare workers of the necessity to protect this person in as many ways as possible. And especially for young people, many of their issues difficulty could be related to financial pressures, academic issues. So we have not just the social worker taking the relevant information to help the individual, possibly financially, but a psychologist or a counselor or a therapist who is able to diffuse the situation. I believe that in moving forward, we have to bring awareness to what I call cognitive diffusion, diffusing the situation where the person is able to maybe leave that emergency ward with a little bit of hope, with a little bit that somebody listened to me, somebody cared. I could move forward, maybe on broken shells, but I can move forward with a bit of hope. So yes, data collection, I said, has to be robust, has to be reliable, but it must be connected also to the training and development of our healthcare workers.
Yeah, very, very important. I think definitely looking at suicide from as a national health priority is something that is coming up quite a bit in our conversation. And on that note, Dr.
Yeah,
Ramirez, anything you would like to chip in?
you muted.
Dr. Yes.
Uh-huh.
Dr. Ramirez, you're still on mute. Maybe you could try rejoining. Okay, so while Dr. Ramirez does join us back, I have some more time with you, Dr. Chitur. So you did mention that outcomes is something that is important, and that was going to be my next question in terms of when we are looking at crisis hotlines. There are a couple of things, of course, that I could also add in, but I do want to hear from you that what are the best practices that need to be adhered when we're looking at running crisis helplines, especially from a cultural context, like you were sharing earlier.
Uh, you sort of were muted there. What is the? Oh yes, the best practices for running crisis hotlines. That's the question. Yes, I lost you a little bit. So we mentioned it in part. One is the cultural context and the cultural competence training of individuals. So, for example, during the pandemic, we had a lot with the crisis happening in Venezuela. We had a lot of migrants coming into our country seeking help, seeking support. So, in addition to establishing the crisis intervention hotline, what I had to do was do something to have a Spanish psychologist on board also. So, because we wanted to offer that multilingual support to these migrants, I also did a video, Luchando contra el COVID-19, specifically for these Spanish migrants. So we have to look again at the cultural context of our country, not just for our own individuals, but for those coming in, those who need our support, and also to have on board of in the helpline services multiple language trained operators who can communicate effectively in different languages, being crucial. So that cultural competence is necessary. We also have to train our staff. So in developing the hotline, what I had to do before we even launched it was to train, even though we had 18 psychologists on board, train them in crisis intervention techniques, specifically understanding how cultural factors may impact the coping strategies. What about emotional expression, the privacy and the confidentiality of our callers? And even though these are professionals, you have to reiterate, because a crisis hotline is not offering ongoing therapy, it is offering solution focused therapy, brief therapy. People don't want to be on there, they just want to come on board. They want you to listen to them, and they want you immediately to help them. So yes, going through all of what they know, the brief solution focused therapy, etc. And understanding underlying all of this is a non-judgmental attitude in the hotline, helping them to maintain this and not to impose sometimes any personal values. And again, we chose professionals who know about all of these things, but just to reiterate them to support the helplines. And I remember in that first week we had more than 500 callers when that people was just reaching out. They were glad to know that, wow, we have a hotline, it's free of charge, we don't have to pay, and somebody is there to listen. And they not only called upon mental health issues, as during the crisis many of them had lost their jobs. We had a lot of men calling in who were businessmen, lost their jobs, thought of suicidal ideation, didn't know how to cope, wanted to know strategies. So I think when we look at running crisis helplines, we have to look at what's happening in the country at the moment. How can we implement procedures to help our sample population, to help our men, to help our young men, our university graduates who did not finish university? Those who had finished were launched into not having jobs in a situation where their parents had lost their jobs. We had secondary school students who were not completing their final exams but leaving schools to go and find menial jobs to assist parents, so you have to understand what was happening in our country. How can we speak to that? And on another note, I am the director of the MNC Psychological Testing and Counseling Center. In addition, we had to rally around our helpers to provide financial, not just mental health help, but financial help to these persons who we knew were being swallowed up into a situation that they did not really understand. Yes.
Yeah, I think crisis headlines are definitely a low resource intervention that can be leveraged, especially for the advantages of accessibility, anonymity, and the ability to, I think, link individuals to psychosocial resources in a way that in person interventions necessarily can't. But as you mentioned, I think without quality, without certain prerequisites, it would not be meaningful to have these around. And Dr. Ramirez, glad to have you back. If I could ask you to tell us a little bit more about the best practices for running crisis helplines, as well as anything you want to add around how to sort of monitor effectiveness of these interventions.
Yeah. Okay. So about the crisis helplines, and I guess like linking that to monitoring. So I know here in the Philippines, one of the things that they have been trying to explore is how to measure the effectiveness of the crisis helplines, and trying to like what are the effective ways of, is there a way to follow up individuals who have called while still ensuring that we keep privacy and confidentiality? Is there a way for us to interview them after, so that we can actually extract that kind of data? So I think with a lot of the kind of crisis hotlines, but suicide prevention in general, in terms of evaluating, I think we need to do a lot more, both quantitative and qualitative research. We really need to hear like these stories and experiences of individuals who have um, received certain interventions, so we can kind of distill the key elements that are effective in these different interventions. So as mentioned earlier, so the crisis hotline can be there, the training prerequisites can be there, but there are different variables that we might not really understand unless we talk to the clients and have that data collected regularly and systematically. Um, and I want to go back to the point earlier about the data privacy. And yeah, I'm so glad that you brought that up, because I was thinking about that. And that is something that always comes up in conversation. So here in the Philippines, we have a specific Data Privacy Act. So like everyone is kind of wary of like sharing data, because we have a law and there are certain penalties. But in addition to what was shared, in terms of increasing awareness and training the individuals who are like the health professionals, for example, or the support workers, I'd like to complement that by adding the need for policy to address specific like practical considerations. So first, in terms of declaring any history of suicide attempt, or if it's a death by suicide in any documents, there will be implications in terms of accessing health insurance. There might be implications of if an employee of a company, or for example, this is a police officer and there's a history of a mental health disorder, even not even just a suicide attempt, but if a mental health disorder, that can be grounds for dismissal from their work. So I think in addition to increasing that kind of awareness, we really have to work on the policies. Are there clear protections that if that is written in a document, it will not be taken against them, and there are clear mechanisms of how we can protect these individuals, and that will not be used to take away their financial benefits, their employment benefits, that will protect family members as well. So if those barriers continue to be there, then no matter how much we educate and increase people's awareness and understanding, um, that will not change. The behavior will not change. Everyone will still not want that declared in any document, and they will not want to talk about it. They will not want to reach out to ask for help. So I think that's where the government policy work needs to step in a little bit more, be more proactive in terms of that, because the practical considerations are very real. And for example, if this is an individual who um, died by suicide, and how apart from the loss of the life of their loved one, how does the financial implications, the benefits that they receive as a family from the individual, so what are the implications of that? So the cultural and educational concerns are there, but I think we really have to work on that. And someone who working on policy, that's hard. Even if we have a law that's very general, that this entails talking to insurance companies. And of course, like they have their own targets and like their own focus. So how do we find that balance that advocates for this as a mental health condition, as something that is a shared goal and responsibility, but at the same time, really have clear guidelines on how to implement that in real life, in daily life, so that these are not just things that we say, but they're actually documents that can protect individuals and their families.
Very, very crucial. I think looking at, I mean, even when we are talking about whether it's a crisis helpline or any sort of suicide prevention intervention, it cannot be looked at as an individual silo, but something that is impacted by social barriers, like implications, as well as I think just legal barriers as well, and for it to work effectively, we do need to consider whether it's the warning signs, the environmental factors, risk factors, protective factors, as well as I think both of you mentioned providing psychosocial support in some or the other manner, whether it's providing economic aid, legal support, or just policy level changes that are happening. Duly noted. And I think this also brings me to the last question, which is around considering the breadth of both of your work. Are there any region specific challenges that you see in suicide prevention? And any of you could go for this.
So I suppose we could look at the takeaways here, or look at what's happening. So yeah, in suicide prevention, again, we have to look at public awareness. That's a challenge, getting people to understand that this is a public health issue and linked to their physical health, also linked to a lot of the NCDs that they may have, to challenging that stigma, that discrimination, that bias against persons with mental health issues, and not seeing them as weak, not seeing them as disempowered, but seeing them as persons in need of help. And hopefully, lots of initiatives that can be supported locally, getting our stakeholders involved, because many times people dismiss persons with mental health issues in the workplace, in schools, children. They see children as they have mental health issues and they trivialize the concerns of children. So it is really supporting the initiatives, challenging the stigma, bringing more public awareness to our programs, and lastly, promoting culturally sensitive practices in our work with mental health persons.
I think you summarized that very well. And if I could ask you to leverage the online medium to also put, maybe a tweet length takeaway that you're hoping the audience to have from this, what would that be?
So, yes, the regional coalition is on board. We are seeking momentum to take it to Parliament. We have lots of persons who are advocating for the decriminalization of suicide. So, I want persons to be alert to get involved in your community, in the persons around you, and let us bring mental illness into focus and help our persons.
Thank you, Dr. Chatur and Dr. Ramirez.
Well, I've been advocating for data and surveillance. So I would say that, yeah, data is power. And this data is not just data that we can count, but stories include that data as well. So let's collect more data, collect more stories, and listen to more stories so that we can together create a better story of hope that we can all share.
And just like that, I think we're at the end of time. I know how busy both of you are, so I truly appreciate you taking out the time to join us. And I would also like to take this opportunity to thank all of the audiences for joining in from all different parts of the globe and at whatever ungodly hour it is for you to join the session. There were quite a few takeaways from a subject that even today we don't talk about very often, or it's flooded with a lot of misinformation, stigma, and hopelessness. So I think this was a light of hope at towards that. Um, I also want to request the audience to fill out a quick poll that might have appeared on your screen right now. And finally, I think a round of gratitude is also overdue to the logistics team, which involves Ali, Catherine, and Divya and Laura for facilitating the logistics for this session. With this, I think the session could come to a close. Thank you so much for your participation.
Thank you for having us here, Gigi. Thank you for all of your work.
Thank you very much.